you have, about 40 minutes for your talk, and then you
Great.
can take questions, and I'll monitor the chat box, and
Perfect.
I will group them.
Very
And
good.
one of the reasons, Dr. Rauf, one of the reasons we started this is because as of 1 month ago, things looked very bad in India. And there was a great shortage of knowledgeable staff. Many junior people were being recruited to the battlefield. So we thought every night we would find people who are knowledgeable, who already lived through COVID, understand pulmonary critical care and infectious diseases. And this is the 28th such session every night.
God bless you, and really such a wonderful service that you provided. And I know Kay was intimately involved, and she was seeking speakers from here. Hats off to you. So much needed, and in the process, both sides learn. I'm looking forward to learning from my colleagues in India.
So she found us many, many knowledgeable, experienced speakers. And tomorrow, in another 2 days, we'll end nightly session, go back to weekly, because it has been, as you probably know, things have cooled down a bit. And
Happy to hear that.
in India, things turn out to be more supplies, drugs, amphotericin B, oxygen, rather than lack of doctors at this moment, I think. So
Right.
we'll slow down a little bit from now on. We'll start in another 2 or 3 minutes, sir.
Sure, absolutely. And then I'll be able to share my screen.
Yes, he is ready. He already gave you share screen. You could actually right now open your PowerPoint and share screen right away.
Okay, let's do that. That's a good idea. Can you see the screen in the
Yes.
full mode?
Yes, we can see. Yes.
Perfect.
Very good.
Perfect. Usually, we have many people who log in by 8:05, 8:06, and they will continue to come on until 8:10 or so. Host is the principal of Andhra Medical College in Visakhapatnam. He usually there. Otherwise, Dr. G, Dr. Buddharaju, and I usually monitor the screens.
Right.
We'll start in another 2 minutes.
Perfect. I'm at your beck and call. When you say the signal, I'll start.
Have the cases gone down in your place, Suhail?
We have really, in all the 23 hospitals of Northwell, we had only 120 cases. We have closed all of our COVID wards, additional ICUs at Lenox Hill. And basically today, I think we had 2 cases.
Great.
So it's staying down. The question, the concern is, now that people are having this release, you see the restaurants are completely full. And, Kay, on Saturday, we had the Chest Foundation dinner, and all the people there, probably around 250, 300, were in a restaurant ballroom, all pulmonologists. And I was really concerned to see that nobody, not one person, was wearing a mask. And obviously there was no social distancing when you have so many people.
Yesterday we had a fellows graduation, and after a year and a half, I've seen the rest of the face of, the Baylor has said we can gather without the masks. So we'll see what happens.
Yeah, I just hope everything works out okay. It's a little scary.
Dr. Rauf, is it fair to assume the 250 doctors, the pulmonologists, had received 2 shots of the vaccine?
I think so. I can't be 100% sure, and they certainly did not ask for verification. but I would say the vast majority have. There are some much less physicians, more nurses, more respiratory therapists in our hospital who still are reluctant. And then non-physicians, there are people, there's nothing hidden here. The Republicans are much less likely as compared to the Democrats to not get a vaccine. So it's just, what is the purpose of being educated if you can't use education to your advantage? I have had people who were dying of COVID in the intensive care unit who were saying, look, this is all a farce, this is all a lie. I don't have COVID, I'm dying from other causes. So somehow some people have this concept so badly ingrained in their minds that COVID is non-existent, that COVID is a fraud, that physicians are saying that they have COVID because they want to make more money. It's really very disheartening and very pathetic.
It's very sad.
Ram, shall I start?
Yes, you can begin. Go ahead, Dr. Guntupalli.
It's my distinct pleasure to introduce my very good friend, Dr. Suhail Rauf from New York. Suhail obtained his medical degree from Maulana Azad Medical College in Delhi, and subsequently did his residency and fellowship in New York in Nassau County. And currently he's a director of the Lung Institute at Northwell Health, and he's a professor of medicine and radiology at Donald and Barbara Zuckerberg School of Medicine at Hofstra, Northwell, New York. Suhail has a very interesting background. He's a very well-known pulmonologist, very well published, but he has a great interest in radiology of the chest, and he works with one of the top minds in Radiologic Society. He's one of the very few clinicians, pulmonologists that I know who has been invited to be a member of the Fleischner Society, which is a very prestigious radiologic society. Among the many, and he has published extensively, among the many titles and many services that he has done, he was a past president of American College of Chest Physicians in 2012. And he has received so many awards. I think it'll take me, several minutes. So I'll stop there, and looking forward to your talk, Suhail.
Thank you so much, Kay. Dr. Guntupalli has been a beacon of inspiration for so many of us, especially those who came from overseas, such as India, and she has just held the banner so high for all of us. So it's really a pleasure for me and a distinct honor to be introduced by her. Thank you, Kate. Before I begin, I just wanted, if I can, to spend a minute talking about an individual who had also inspired us, Om Sharma, who was a master of the American College of Chest Physicians. He is widely considered the father of sarcoidosis because when he started his career, very little was known about sarcoidosis. I had the distinctive pleasure of being mentored by him and working from a distance with him for almost 30 years. His advice to his younger colleagues was, know your skill sets, develop those skill sets, and then become the best you can be so that everybody around you comes to you as the expert in that area. Pursue your passions, become the best. He has mentored thousands and thousands of individuals like me. And whenever I had a difficult case, he was on the West Coast and I'm here in New York, I would call him and I was assured that if he was not able to answer my call right away, in the next 15 minutes to a half hour, he would always call. And I was amazed at how much time he would take in hearing about the cases and then giving the best of advice. His motto was, be the best you can be. So one day when he had gone to Japan for a conference, someone was playing the shakuhachi, which is a very difficult instrument to play. And Dr. Sharma felt that he was going to learn and master the art of playing the shakuhachi. So if you can imagine, he went from the West Coast to Japan several times to be able to get hooked up with a master in the instrument, and he would go there and play this instrument until he had mastered it. Such was the man. We often think of him and we miss him deeply. So what I will be talking to you is an article that has just recently been published ahead of print in Chest, and it pertains, as I said, to the topic of the utility of CT scanning in the diagnosis, in the treatment, and in the prognostication, and in the management of subacute and chronic complications of COVID-19. So the objectives of this presentation will be, should chest CT be used in the diagnosis of COVID-19? And I would submit to you the answer is no. CT scans, however, do have a role in the acute phase of COVID-19, where, as I said, the CT scan may be used to stratify the severity of illness, to look at prognostic factors, to look at the rapidity of progression of disease, and very importantly, look at complications. And now, as the pandemic is slowly ebbing down, we find that many of the patients who have survived the acute illness are left with chronic disabilities, hypoxemic respiratory failure, and an inability to pursue their regular lifestyle. How can the CT be useful in assessing the fibrotic-like lung disease that we are encountering in many of these patients? And finally, in the individuals who had pre-existing interstitial lung disease or interstitial lung abnormalities, what happens to their disease if they come down with COVID? And I would submit to you that there is an acceleration of the disease process, and I will show you some images for that. So let's talk about a consensus statement that originally came out from the Fleischner Society in the month of April 2020, which is that CT imaging is not indicated as a routine diagnostic modality, or even in a person who may have been exposed, or the person is asymptomatic. CT scanning should not be utilized to look for ground glass opacities in this asymptomatic patient who may have an exposure to the disease. And in individuals who have known and diagnosed COVID-19, let's say with a PCR, as long as they have mild features and as long as they are not at risk of progression of disease or the development of adverse outcomes, routine utilization of CT scanning in such individuals is not likely to be helpful. So where is CT scanning indicated? It is indicated in those patients who have a severe or moderately severe disease that is showing rapid progression with worsening respiratory status. These include patients who may have a negative PCR where you have a high index of clinical suspicion. And it has utility, the CT scanning, in individuals who have functional impairment and remain hypoxemic after recovery from the acute phase. Now, what is the basis for this recommendation? CDC, the ACR, and the Fleischner do not recommend routine use for very specific reasons. Sorry. The reasons are that the findings on CT scan are non-specific. So if I look at the CT scan and I find that there are ground glass opacities or dense consolidation, especially in the peripheral segments of the lung, then yes, it could be COVID. But it could also be non-COVID related viral illnesses. It could be drug-induced interstitial lung disease. It could be autoimmune related interstitial lung disease. It could be organizing pneumonia. So even though the CT scan is specific, there are many other reasons to have the same kind of CT findings that COVID confers on the patients as non-COVID related conditions. And it is also important to remember that in the first 3 to 5 days of the patient acquiring the illness, the early phases, CT scan may remain normal and it does not rule out COVID-19 infection. On the other hand, there are also increased risks of dispersal of the viral particles when you send the patients down to the radiology suite. And as India went through and New York went through last year at about the same time, when you have a full-blown pandemic, there is so much of constraint of resources, of PPEs, of gowns, of gloves, of N95s, that it becomes very, very difficult at that time with so much resource constraints to be able to get downtime in radiology suites, to clean the suite, and to utilize PPE for the respiratory, for the techs who are working in those areas. So I want to submit to you a case that we had where the CT scan was useful. This was a person who was admitted to our hospital in the month of June. And in this instance, the patient was severely hypoxemic, and you can understand the reason why. We had a high index of clinical suspicion that the patient had COVID-19. However, the PCR was negative ×2. At that time, it was significantly more difficult to get remdesivir, and we had to have another layer of insulation when we called at that time our releasing agency to get remdesivir released. And when we got the CT scan, the CT findings are very typical, and that gave us the additional boost that we needed to say, this is a person who has, in all likelihood, clinical and radiographically, the COVID-19. Now, one of the things that I would like to mention to you is when you look at the variety of molecular tests, rapid antigen tests, and serological tests which are available, in the vast majority of instances, with one exception, and that is PCR and the BAL. With this exception, the general sensitivity for other molecular tests is anywhere between 30 to 60%. However, if this test is positive, it is very likely to be a true positive test. On the other hand, when you look at the CT scan, especially after day 3 to day 5 of the patient acquiring infection, and especially in moderate or severe disease, the sensitivity is upwards of 90%. But for the same reasons that I described earlier, the specificity is low to the tune of 50%, because other viral illnesses, drugs, etc., can give rise to the same CT findings. So what I'd like to do now is to talk to you about the imaging classification. And I have to tell you that I have co-managed many of the patients from India with my colleagues in India. And I was so proud to see that the Indian radiologists and the pulmonologists really do utilize the RSNA COVID-19 imaging classification, as well as the CORAD score that we go, much more than we do here in United States. So the RSNA COVID-19 imaging classification is divided into 3 appearances. One is a typical appearance of COVID-19. The second is indeterminate. And the third is suggestive of some other disease other than COVID. So let's talk about the typical appearance. What I would submit to you is that the presence, again, in the right clinical context, the presence of peripheral, generally bilateral, ground glass opacities with or without consolidation is what is seen in the beginning. Within about a week's time, you can start appreciating crazy paving, and I have some images to show you. And between day 7 to day 14, you can have CT evidence of reversed halo sign suggestive of organizing pneumonia. The indeterminate appearance, on the other hand, is the absence of these distinct four classes, these distinct four patterns. There may be multifocal diffuse instead of subpleural peripheral diffuse opacities. There may be opacities that are not present in the periphery, but may be present in the perihilar area. There may be unilateral ground glass opacities, but of course that could be early on in the course of the disease. And then the atypical appearance is appearance that is typical of other conditions. So let me show you the typical features. Let's begin with two specific features. The middle panel shows ground glass opacities that are present. Here I'm just showing you one-sided axial images, but this is on the right side. You can see ground glass peripheral opacities. In the left-hand panel, you see the ground glass opacities here in the ventral areas. In the dorsal areas, there is dense consolidation that is present. So a composite of either ground glass or ground glass with consolidation. Now, the third image on the right side that is depicted is actually ground glass opacities, but these ground glass opacities are not in the periphery of the lung. They are present in the mid portion, and frankly, some of them are closer towards the middle 1/3 of the lung. However, there is one other defining feature in these ground glass opacities, and that is a rounded appearance. And so when you have rounded appearance, ground glass opacities, even if they are away from the subpleural areas, all three of these images are suggestive of typical features of COVID-19 pneumonia. So the remaining two typical features that develop a little later are the interlobular septal thickening in the milieu of ground glass opacities here. So interlobular septal thickening with ground glass opacities. This is the secondary pulmonary lobule that is outlined. And then you need another feature in this to call it crazy paving, which is within the secondary pulmonary lobules, you have to see intralobular lines. So the presence of ground glass opacities, interlobular septal thickening, and intralobular lines define crazy paving. And when you see crazy paving, there are two specific inferences that you can make. One is that there is the process of fibrosis or a fibrotic-like reaction that is taking place, and that correlates with the intralobular lines. And the second is that this process has been present for approximately 14 days or more. Now, this is an example of a reversed halo sign where there's an area of central ground glass or central clearing, which is surrounded by dense consolidation. And this is quite typical for organizing pneumonia. Let's talk about the indeterminate appearance. The indeterminate appearance is, in this instance, a single ground glass opacity that is present. And you can see that this is the axial and this is the coronal images. And yes, it is very likely that this was caught early on. In fact, this was a CT that was done within 24 hours of the patient hitting the emergency department, relative paucity of symptoms. And 4 days later, when the patient showed worsening, you can see that now there is nothing left to imagination. You can see reticular opacities that are present more so in the mid-lung zone on the right side, but certainly also visible on the left side. Another example of indeterminate appearance, where you have these patchy ground glass and areas of consolidation, but these are extending all the way from the periphery to the perihilar areas, and they do not show a rounded distribution. So this becomes indeterminate. Could this be COVID? Yes, it could. Could this be other conditions that we talked about? Yes, it could. These are ground glass opacities that you can see with a non-rounded appearance. And so there's no specific distribution. Some are subpleural, peripheral, some are more central, and therefore this would still be considered indeterminate. And a typical appearance is an appearance that strongly suggests an alternative diagnosis. As you can see, there is ground glass diffuse opacification. You can see interlobular septae that are thickened, and you can see a pleural effusion on the right side. This is a person who has heart failure and pulmonary edema. This is an example of a person who has tree in bud opacities. Note that it is not reaching the periphery of the lung because airways don't reach the periphery of the lung. And this is the typical tree in bud or budding pattern that you see with bronchiolar infection or inflammation. And this is a patient who had dense consolidation with the air bronchograms, nothing else seen in the lungs. Patient came in with high fevers, chills, rigors, and turned out to have a pneumococcal lobar consolidation. So those were the typical, indeterminate, and non-typical suggestive of other diagnoses. The second aspect that I wanted to leave you with is the COVID-19 reporting data system called the CORAD score. Now, this is something that was originally propounded by the Dutch Radiological Society, where they looked at separating the COVID-19 patients with moderate to severe disease into those who had very little likelihood of having COVID, with going all the way to a stage 4, COVID category 4 or 5, with a very high rate of COVID. And so if you look at it, the scoring goes from 1, which is very, very unlikely to be COVID. And here the false negative rate is about 5.5%. So if this doesn't look like COVID to you and you say CORAD's category 1, you are likely 95% of the cases to be correct that this is not COVID. Going all the way to category 5, which is very high likelihood, as we talked about with the peripheral areas of ground glass, consolidation, etc. Very high likelihood with a false positive rate of less than 1%. And a CORAD's category 4 and above is the one that has been shown to correlate well with a positive PCR. Category 6 is category 5 with a positive PCR. So that is diagnostic. And to give you examples of COVID lung RADS, CORADS 1, very low likelihood. This is a spiculated mass, which was a bronchogenic carcinoma, single mass here. This is a patient who has advanced confluent emphysema. You can see areas of hyperlucency without defined walls. And this is an example of emphysema. So both would be considered very low likelihood to be COVID, and this would be CORADS 1. This is an example of a patient who had focal necrotizing pneumonia. This was not diffuse, and this was read as low likelihood, so CORADS 2. In contrast, CORADS 5, which is peripheral rounded ground glass and subpleural areas of also of consolidation, This is typical, and this was read as CORADS 5. So let me tell you a little bit about the acute phase of COVID-19. We'll focus on the prognosis, prognostication, and complications. So what I'd like to submit to you is that there are two ways in which we can prognosticate the severity of the disease and hence the mortality rate of the patients. This may also be utilized in the emergency department in deciding who should we admit and who should we not admit. Who should we take once admitted to the intensive care unit or a monitored bed versus who can we keep safely in a non-monitored bed. And there are two ways you can do that. One is to look at the extent of involvement of the lung, how much of the lung is involved. And the second is by looking at the vascular involvement that has also been shown to correlate negatively with prognosis. So let's look at the study that was published in the European Journal of Radiology, and Franconi was the first author in this. What he did and his colleagues did was to divide the lungs into the 5 lobes, 3 on the right side, 2 on the left. Then they broke up each of the lobes into the extent of involvement of opacities, of ground glass, of consolidation, of crazy paving. 0 was no involvement. 1 was less than 5% of the lobe was involved. 2 was 5 to 25% of the lobe was involved, so on and so forth, with 5 being greater than 75% of the lobe was involved. And this is an example to give you that this is a tedious process, and you can use artificial intelligence and axial imaging modalities, but computerized tomography imaging can be used. But in this particular instance, let's take the example of these patients in whom we are looking at the right lower lobe. So you have to look at the axial, the sagittal, and the coronal images, and the right lower lobe in either of the 3 images is not involved, giving a CT score of 0 of the right lower lobe. Let's look at this example here. In this particular instance, there is between 5 to 25% involvement on the axial, sagittal, and coronal images, and therefore this gives this patient's right lower lobe a score of 2. So you compile the scores of the right upper, middle, lower, left upper, and left lower lobes, compile the scores, get the average, and then figure out. In general, if more than 3 lobes are involved with over 75% involvement, the mortality 30 days tends to be about 50%. And this is an example to show you that this patient had significant involvement of the lungs, and these are, of course, incomplete in assessing, but you can imagine the axial, the coronal, and the sagittal, and visualizing each of the lobes. Here you can see that there is an intermediate severity, significant involvement, giving a total CT severity score of 12. And this is an example of a patient who had much more extensive involvement, giving the patient a severity score of 15 and therefore a high mortality. So over a period of time, these studies, this data has been substantiated and validated by others. And I submit a study to you, which was published in Chest, that said that if the CTSS score is less than 3, the patient can be discharged from the emergency department, provided there aren't other extenuating clinical circumstances. A CTSS score of greater than 10 is predictive of hospital admission, greater than 15 predictive of ICU admission, and greater than 15 or 17 specific for a high 30-day mortality. Now let's talk a little bit about vascular changes defining poor prognosis. So we should also look at the blood vessels on the CT scans. look specifically for thinning or engorgement or enlargement of the blood vessels. Look for distortion of the blood vessels and specific angulations in the blood vessels that tell you that the blood vessels are involved by the cytokine surge. So I would like to submit to you that these are the normal blood vessels that are present in areas of the lung that are not affected. So these are subsegmental blood vessels, therefore they are less than 3 millimeters in diameter. But let's look at what happens to the blood vessels in the areas where there is supposedly inflammation, where as a result of the cytokine surge, there has been damage to the lungs, where cytokines have been released, there's been an increase in permeability of the blood vessels, there's been an escape of edema fluid in the alveolar compartment. Look at what has happened to the blood vessels. These are the subsegmental blood vessels, much more dilated, more than 3 millimeters, signifying again damage and swelling of the capillaries because of the pro-inflammatory response. These are normal blood vessels, these are dilated blood vessels for you to consider. I'm going to skip through this. If anybody has any questions at the end, I will be happy to talk to you about the segmentation of blood vessels and the concept of BV 5% and how the subsegmental blood vessels, the volume in the subsegmental blood vessels goes down very significantly, and that is associated with a high mortality rate. One other important thing to remember is that just the same process can take place in the heart that we saw happening in the blood vessels. If there is significant myocardial inflammation, then you can start seeing pericardial effusion, and that is again a marker of just intense inflammation taking place in the cardiovascular system. Let's talk a little bit about how the CT can help identify steroid responsive diseases and also help us in understanding what may be the complications in patients not doing well. So this was a patient we had in the month of June, and all of you will agree that there are peripheral dense consolidations. There may actually be a reversed halo sign here with more dense consolidation, and so this would be suggestive in the right clinical context of COVID-19 with the development of organizing pneumonia. The patient got 10 days worth of dexamethasone, and then we stopped the dexamethasone. No significant improvement from June all the way to August. In August, we sent the patient for a surgical biopsy because he was quite hypoxemic on exercise, had a diagnosis of organizing pneumonia established, and gave the patient 6 weeks worth of approximately 0.75 milligrams of prednisone a day with significant improvement. This is an example that my good friend Atul Mehta in the Cleveland Clinic had given us. This is a patient with COVID, and you can see ground glass opacities with consolidation, reticulation that's developing, intralobular septal lines that we talked about. But in addition to that, you see that there is necrotizing pneumonia, the development of pneumothorax, and the chest tube that was placed. So this patient grew MRSA in the blood and Stenotrophomonas maltophilia in the bronchoalveolar lavage. So this is an example of a patient who developed complication of COVID pneumonia with necrotizing bacterial pneumonia. In our hospital, and we saw over 3,000 patients in the 6 months when COVID was raging in New York, we looked and we saw that there was about a 10% likelihood of a superadded bacterial infection and another 10% likelihood of fungal infection, but the vast majority of fungi that we saw were not Aspergillus or Mucor, and I know Mucor has been a problem in the series that have been coming out from India. What about the patient who is hypoxemic, but in contrast to the other cases where we saw significant opacities, in the lungs, there were no significant opacity. So we have to have a high index of suspicion for the second aspect, which is a vascular problem. And as you can see, there are large pulmonary emboli that are present in the right and the left main pulmonary arteries. Note that there is ground glass opacity that's seen in the patients here. So one of the other things that I would like to tell you is those patients who come to you and are significantly hypoxemic. You do a CTPE study and you don't find in the parenchymal evaluation not a whole lot of ground glass opacities, not a lot of parenchymal disease. You look for the CTPE, you don't find macrovascular clots in the segmental, subsegmental, or lobar branches. Yet the patients are hypoxemic. Yet the patients have a high D dimer. When you assess these patients' compliance of the lung compliance is normal. These are the patients who may also have multi-system organ involvement. And the mechanism is that COVID-19 induces a surge of cytokines, resulting in vascular endothelial damage, resulting then the sickness, the hypoxemia, the viral infection results in a hypercoagulable state, and this results in microvascular emboli. What I'd like to submit to you is this CT scan, and this is a dual energy CT scan, where you can see that there is a macro or a visible blood clot that's occluding the apical segment of the right lower lobe. And so when you look at the perfusion images of the dual energy CT scan, you can see an area that is not perfusing, and that corresponds to this macro vascular clot. But now let's take the example where the CTPE study did not show any visible clots. You can see that the lung parenchyma shows significant ground glass opacities. And in this particular instance, there are two specific abnormalities that your dual energy CT scan is showing. If you look at the areas of ground glass opacity and look at the corresponding perfusion images, there is an increased attenuation or a bright signal that is seen. That's telling you that the blood vessels are dilated. There is an increase in the flow of blood that's going to the periphery of the lung. And that corresponds to the areas of the lung that have this ground glass opacity. But note something else. In adjacent to these areas of hypervascularization or increased perfusion, there are these black areas. And these are the black areas where there is lack of perfusion. And this signifies microvascular emboli. And we have had a few patients at Lenox Hill Hospital where we had no particular reason for the patients to be hypoxemic and desaturating when they walk. And when we got the dual energy CT scanning done, we found that the patients had this specific pattern. So it's important to remember that there are three interesting findings in specialized CT scans. Unexpected proximal artery thrombosis in about 5.5% of the patients, disseminated hypoperfusion or the black areas indicating microangiopathy in about 65% of the patients, and then the ground glass areas corresponding to increased perfusion as a result of cytokine surge causing vasodilatation. Okay, I can stop here and just entertain questions. This last segment will take me about a little over 7 minutes or so. So I don't want to run over. I can stop now.
I think this subacute chronic would be very interesting. I would like to, if it's okay with Dr. Ram, I think we should go ahead.
Okay.
Go ahead, Subal.
Thank you. So how do we know that if a patient has gone from the acute to the subacute or chronic phase? The ground glass opacities will initially progress to dense consolidation in 3 to 5 days. Then, as we mentioned, you can start seeing the development of crazy paving, and you will be able to see the reversed halo sign suggestive of secondary organizing pneumonia, usually from day 7 to day 14. I also want to warn us all that in patients who have underlying interstitial lung disease, underlying interstitial lung abnormality, there seems to be an acceleration of their baseline fibrotic lung condition if they come down with COVID-19. And we had a few cases at Lenox Hill that I'd like to submit to you. And then, of course, some of the patients who develop end-stage lung disease and who show no reversibility over a reasonable period of time may be considered for lung transplant assessment. So this is an example of a patient who has developed this reversed halo sign. Remember that there is the presence of intralobular lines, suggestive that this is a chronic process, chronic meaning more than 14 days or so, 7 to 14 days, and there is the development of this reverse halo sign suggesting organizing pneumonia. These are the patients in whom giving only 10 days worth of steroids is probably not going to be enough. And if they show an improvement, there's almost a 50% likelihood that this will relapse if the steroids are stopped. And this is the example of intralobular lines within the confines of the secondary pulmonary lobule, signifying chronicity and fibrosis. This is the development of subpleural curvilinear bands in the right lower lobe, as you can see, suggestive that a fibrotic-like process is setting in. And this is what happens to the patients this is what happened over a 3-month period in one of our patients, extensive ground glass opacities and consolidation. The more extensive the ground glass opacities and consolidation in the beginning, the more likely it is that there will be residual damage. And so when you look here, the ground glass opacity has more or less become much less. In the place of consolidation and ground glass opacities, you find coarse reticulation that is present, intralobular lines, and very importantly, you can see that the airways are getting pulled apart, and this is the traction bronchiectasis. Now, in almost all other conditions other than COVID, so autoimmune diseases, hypersensitivity pneumonitis chronic, if you see traction bronchiectasis, if you see these fibrotic lines, then in almost all those cases, it is suggestive that this is an irreversible process. But I would submit to you that in the setting of COVID-19, this may still reverse after 3 months, after 6 months, because there are very immature fibroblasts that are laid down very quickly, and they can be remodeling with the absorption of these changes in COVID. So this was an important study by Hahn et al. That came out in the earlier part of this year, where they looked at 114 patients who had severe disease, COVID, proven COVID. They were admitted, all of them, to the hospital. And then after discharge, they had a CAT scan that was performed at 6 months after their illness. And this is the rule of 1/3. A third of the patients had fibrotic-like features typified by irregular bands, irregular interface, traction bronchiectasis, and in a minority, even honeycombing. About a third of the patients had persistent ground glass opacities with some interstitial thickening, as we showed in the prior images. And a little less than a third had complete clearing. So these are over 100 patients, severely ill, admitted to the hospital. And what was it that distinguished the patients with fibrotic-like features from those who had complete clearing. And I hate to say this because I left this age barrier many years behind, but age of greater than 50 years, severe disease, and in their series, they defined they defined hemodynamic instability, heart rate of greater than 100 per minute, or a prolonged length of stay of greater than 17 days, the CT severity score of greater than 18, the development of ARDS, and the necessity to utilize mechanical ventilation, either invasive or non-invasive, defined which patients would develop fibrotic features. So in an elegant editorial by Ethel Wells, it was pointed out that we have very sparse histopathology on these patients. And if we do, then there are two major patterns of damage. One is the diffuse alveolar damage, which is either as a result of toxic viral effects or ventilator-associated lung injury or self-induced lung injury. And the second is an auto-inflammatory pathway from vascular processes and from organizing pneumonia. As I mentioned, they do caution not to consider what we usually consider as irreversible changes to be that irreversible in the setting of COVID-19 because of this phenomenon of remodeling and reabsorption of immature fibroblasts. Now, this is a point that is important, which is patients with ILD who had post-COVID had greater than a 4-fold adjusted odds ratio of death. And why is that? It seems that SARS-CoV-2 infection results in lung injury due to a maladaptive immune response. All of this is coming from the cytokine surge. And if a person has an underlying interstitial lung disease, it can get exacerbated. And this was a patient we had who had Sjogren's disease, pretty bad, did have a requirement of 2 liters of oxygen at baseline when the patient ambulated, and you can see the serologies. This patient had a CT scan that showed fairly dense opacification, as you can see in the axial and the coronal images. This was June 2020. Patient came down with COVID, and this is December 2020. Now the patient has dense opacities, more confluent, has developed these cystic changes, and now requires 7 to 8 liters of oxygen for the purpose of ambulation. And finally, the last part is lung transplant assessment, which is when you confirm that there is the absence of other organ dysfunction and the patient has irreversible disease not getting better, then you can consider lung transplant. This is also from Dr. Atul Mehta's series from the Cleveland Clinic. Dense wipeout of the lung on both sides. The patient was maintained on ECMO. You can see the CT showing that there are really there's no viable lung left, and this patient was sent for transplant. So in summary, we've talked about the perspectives of CT scanning with very limited utility for the actual diagnosis of COVID-19. We talked about the utility of CT scans in the acute phase of COVID-19 for the purpose of looking at progression of disease, using a severity score to assess prognosis and looking for complications, and finally looking at the CT scan to decide about subacute and chronic complications that may set in. We would recommend not calling it fibrotic lung disease at this stage, but calling it fibrotic-like lung disease. Thank you for your attention.
That was an excellent talk, very clear, very concise. Thank you so much, Suhail. While people are maybe typing in their questions in the chat box, I just have a comment and couple of questions for you.
Yeah.
You mentioned in a cup organizing pneumonia that you would give steroids. I think it was probably a slip of your tongue. You said 0.75 milligrams of prednisone. You mean 0.75 per
0.75
kilo.
milligrams per kg. Thank you,
Okay.
Kate. Appreciate that.
Okay. The one question I had is, you talk about this scoring system developed here, but I agree with you that nobody is reporting like that. Our radiologists are not, whereas every report you get from India has a score. So they have been really meticulously following that. You talk about 50% mortality in the patients with, extreme involvement of the lung radiologically. As you know, in ARDS, it is bilateral diffuse involvement from non-COVID causes that we have seen in all these years, but we never followed these radiological guidelines and this is a lot of ARDS compared to what we ever saw in 1 year. We are seeing in maybe less than a week. So, I mean, in severe ARDS, moderate, whatever, you will still have bilateral diffuse infiltrates. That's the definition of it. And even in severe ARDS with less than PO2 FiO2 of less than 100, the mortality may be upper 30s to maybe 40%. So how do you think this is a different disease with more cytokine storm and viral ARDS versus maybe aspiration or something else that may not?
So that's a great question, because you have seen so many of your ARDS patients in the intensive care unit. They may have bilateral lung involvement and are on mechanical ventilation. But I think that in this particular disease, the cytokine surge is so overwhelming that the extent of involvement in the lungs is just a surrogate marker of whatever else is happening in the vasculature, which is diffuse, which is beyond the lungs. And so the CNS involvement and the renal involvement and the multi-system organ involvement, I think the way I would look at it is that the extent of involvement in the lungs is just a window or a mirror that's reflecting the very rapid onset of the cytokine surge within about a week or so. And therefore, it is not just the lungs that are conferring the mortality, but it is the multi-system organ involvement that commonly closely follows on the heels of extensive lung involvement. But a great question, Kate.
I mean, I think I'm sure you've seen this. If you look at, I think it was in the Blue Journal. If you look at keep talking about cytokine storm. If you look at the cytokines that were measured in ARDS, in the bank samples of ARDS from the ARDSNet in thousands of patients, when you look at it, what we are calling the levels we're calling cytokine storm in COVID are lower than what they had in ARDS samples over the years. So I suspect that, although there's extensive infiltration in non-COVID ARDS, I think it's the organism and there's something else that seems to be more ominous in this particular disease.
So this is a very interesting question. I'd love to be able to get yours and others' involvement. We have seen, Kay, in the patients that we cared for, and you've seen your large share of patients in your ICU, we have seen CRPs, and we were measuring IL-6 levels surging in 24 hours to 10 times what they were the day before. Now, I have to be very honest with you, in the ARDS patients that I had managed in the past, we were not routinely measuring the cytokine values. So I don't know that I can honestly, in my limited experience, put the numbers in perspective. But it goes without saying that the generalized microvascular damage that is taking place, and this has been looked at in the setting of COVID versus non-COVID other viral illnesses, lot more microvascular, macrovascular thrombi, lot more damage to the vasculature that is now being picked up on the dual energy CT scanning. So, I'm curious to hear your views, and if anybody else also wants.
Yeah, I think I don't want to dominate. I see two hands up. Dr. Prem Kumar is professor of pulmonary medicine in Andhra Medical College. Now they've seen literally thousands of patients. I would like to yield to him to ask his question.
At the outset, congratulations, Dr. Suhail. Excellent talk. And thank you very much, madam, for bringing him. And we had a great honor to listen to him. Actually, I have 8 questions. Actually, there are doubts or ruminations from within me. And it could be like a small 5-minute interview. If you allow me to ask the questions one by one, I'll ask. Or if you allow me 1 or 2 questions, and later on, if all the audience is over, then if you allow me, I'll please. Which way
Let's
I should
go
do?
with maybe 2 questions, and then Dr. Buddharazu had his hand up, and then we'll come back to you.
Dr. Suhail, coming to the GGO, ground glass opacity, the basic understanding is alveolitis. But in the sense that if there is an alveolar consolidation or alveolitis, a few alveoli are filled with the exudate, a few are not filled with the exudate, giving rise to a GGO. But if you go into the deeper reading, there is peribronchial and perialveolar microfibrosis below the resolution limits of a HRCT also leads to GGO. So here in this COVID-19 viral pneumonia, is it alveolitis or peribronchial or perialveolar microfibrosis or peribronchial or perialveolar thin laminar infiltrate? What could be the reason for this GGO in COVID?
So I think you bring out a very important point, which is that you may have minimal early fibrosis that even your high resolution CT will not be able to pick up. We don't have the resolution to be able to pick up micro fibrosis or fibrotic process. So that initially will appear as ground glass opacities. And so usually when, and you can look at the ARDS data on this. So in the first week to 2 weeks, it's generally, as we say, the exudative phase where there is an increase in vascular endothelial damage, resulting more of an exudative output into the alveoli. In about a week to 2 weeks, then you start seeing rapid development of some amount of fibrosis. And I showed you the CT scanning where you see very subtle intra-alveolar, or not intra-alveolar, but within the secondary pulmonary lobule, you start seeing very small lines. And so what I would say to you is that in the beginning, the ground glass opacities are more likely to be representing the exudative phase. And then in a week to 2 weeks, when fibroblasts start getting recruited, you will notice that the smoothness or the just the homogeneity of the ground glass opacity then starts becoming a little different, and you can appreciate a little more coarse texture to it. And that's when the fibroblasts are getting laid down, and you can then start appreciating that it's not as homogeneous and uniform as it was in the early stages. But great question.
Dr. Suhail, my second question is, in India, we have done a lot of CT scans. Almost every patient got it, and I have a collection of more than 750 CT scans with me here just in Vizag. So there is no correlation between the CT severity score and hypoxemia. A few people with 5/25 score are having hypoxemia, and people who are having 17/25 are quite stable without hypoxemia. And when we look at as India in the tuberculosis, we have seen extensive destruction of the both bilateral extensive fibrosis and all those things. In such an extensive disease also, we never saw SATs coming below 90%. But in 5/25 score, in some cases, we have seen hypoxemia. Shall I think that, and I have a concept that more than 50% lung involvement should be there at least to notice hypoxemia, unless, except for vascular abnormalities. So what I think is, if 5/25 score showing at such a small score showing hypoxemia, shall I have a suspicion that there is segmental or subsegmental vascular disease like thrombosis? That is the reason why even small scores giving rise to hypoxemia.
Yeah, so I mean, in the lung of your COVID patients, the involvement is either parenchymal or it is vascular. And so in general, the more the lung parenchymal involvement, the greater should be the score. And so if you find that there isn't a whole lot of fibrotic light changes, there isn't ground glass opacities, there isn't consolidation, then it is very likely that you're dealing with the entity that I was describing, which is that they may have either macrovascular emboli or they may have microvascular emboli, which are not picked up on your regular CTPE study. So that would be the mechanism. I think that there are also a few reports that have tried, and this has all been conjectures because you really can't do a whole lot of physiology studies, but the question of where the ground glass opacities have formed and there is vascular dilatation and ectasia, could that be resulting in shunts because there is also lung parenchymal involvement, and in the same areas there is vascular dilatation. So by definition, absent ventilation, increased blood flow, are you conferring a shunt in those areas? So that was another possibility that, this is all theoretical. We don't have any studies on that, so we can't dwell too much, but interesting postulation.
Thank you, Dr. Suhail. And in the end, if you permit me a few minutes, I'll clear my rest of the doubts. Thank you. Thank you, madam.
Dr. Buddharaju, you want to go next?
Sure. Thank you. That was very excellent, Dr. Raouf. I had some very basic questions. The mortality in severely ill patients of COVID who are in the ICU, is it predominantly inability to oxygenate them, or like non-COVID ARDS, is it multi-system failure? The majority of deaths I thought were basically difficulty oxygenating these people and failure to oxygenate these people adequately, number one. Number two, the second question I had is, so there's this vasodilation in the peripheral lung vasculature, presumably from endothelitis, inflammation of the vessels.
Absolutely.
So what happens to the PA pressures and right ventricular pressures through the course of the disease? Do they actually stay low for a long time and then start creeping up as the disease gets worse and in the chronic phase? That was my second question.
Sure. So let's begin with the first one. I'm going to request Kay, because she's seen a lot of respiratory failure. I would submit to you that when you have inhomogeneous lung involvement and you have stiff lungs, it is just, there is going to be the hypoxemic respiratory failure because of ventilation perfusion mismatch. There is hypoxemic respiratory failure because the lung parenchyma is so badly affected in many instances. And then there is also, and significant amount of literature has been written on it, is even in the patients in whom there is no intubation, we were finding volutrauma, barotrauma, we were finding that they were breathing in 700-800 cc of tidal volume, not intubated, but if you put them on mechanical ventilation, their tidal volumes are very high, and there was self-induced lung injury. And certainly, despite our best efforts, we had a significant number of patients with severe hypoxemic respiratory failure, where we were not able to introduce lung protective strategy, even with tidal volumes of 250 cc, the plateau pressures were 45, 50 or so, with a static compliance that was very, very low. And then you had to start thinking of other modalities to put them on. So my feeling is that yes, hypoxemic respiratory failure was one of the major causes, and probably the major cause of death and mortality in these patients. Even though we agree that the vasculature was affected, and there is a recent study that showed that if the kidney failure was worsening, that had amongst the highest mortalities associated with it. But what we were seeing was mainly hypoxemic respiratory failure, inability to oxygenate the patients, and we were putting them in the prone position and large tidal volumes and very rapid deteriorations that were taking place. I think after the institution of steroids, which became common practice, and remdesivir here in the United States, that we, with the steroids, felt that there was probably a reduction in the rate of decline of lung function and improvement in oxygenation. Kay, can you comment on that? What were you seeing in Baylor?
I think that, I agree with you. I will say that, having seen these ARDS patients over so many years, I would say that it is less than 10% of the time that I will lose a patient because I can't do gas exchange in a pre-COVID ARDS patients. You have so many things, tricks you can do that I can get the patient oxygenated, and they may die of something else, but they won't die of respiratory failure in all these years. But that is not true in COVID. We have been losing patients to severe hypoxemic respiratory failure, hypercapnic respiratory failure, young people who've never had lung disease before, and ECMO. I can proudly manage somebody not having to call the ECMO team for, like maybe once or twice a year. But here the disease is very refractory, and you would use all the tricks in the world, we can't get them to oxygenate, and we lost a lot more patients to hypoxemic respiratory failure.
And one of the other issues that had come about was, when do you use non-invasive, when do you use prone positioning, and when do you use a combination of high flow with proning, etc. And that took a little bit of time to clarify. And then there were a few studies that came out showing that if the P2F ratio is less than 150, then modalities such as non-invasive are associated with a high mortality. And in the patients who were put either on high flow or more so on non-invasive, and even put in the prone position, if you found that their spontaneous tidal volumes that you measured of, let's say, for instance, non-invasive, was more than 6 to 7 cc per kilogram ideal body weight. Again, these were surrogate markers of air hunger, and those patients did not do well and had a significantly higher mortality. But I agree with you, Kay, in the past, it was rare to lose patients because of hypoxemic deaths in ARDS. That certainly was not the experience that we had in COVID patients.
He was also asking about pulmonary hypertension.
Yeah. So, we have a pulmonary hypertension center, and I have been involved with the management of these patients. Amongst all the patients that we have followed with hypoxemic respiratory failure, even those who were discharged, even when we found that the patients on dual energy CT scanning had microvascular emboli and areas of mismatch, we had routinely checked those patients with echocardiograms. In fact, in some instances, we had done stress echoes on the patients. And in a few individuals, when our back was to the wall, we really didn't know. We even did right heart catheterizations. Now, these are patients who were discharged and were then seen back in 6 weeks, in 2 months, still complaining of hypoxia and still requiring oxygen. We did not find that the pulmonary artery pressures were elevated. So I think that the microvascular emboli, while causing significant hypoxemia and ventilation perfusion mismatch, were not giving rise to the elevation in pressures that we are used to seeing in chronic thromboembolic disease. So we did not find it. I'm curious if anybody else has had experience with that.
Sohail, I mean, not doing right heart caths or Swan-Ganz, or, the patient load was so much, and, and we're kind of getting away from that. But I would say probably the pulmonary hypertension we saw was more than what we saw in the pre-COVID era, and we used very extensively bedside POCUS.
Yes.
And echocardiogram. And, when patients are deteriorating, you will see the right heart strain, you will see the right ventricular dilatation, and patients are unstable to go down for a CTPE. We empirically treated them. So I think this sickness is so extensive and explosive that so many things we just did because they were so unstable. You didn't have chance. Of course, in the post-COVID patients, in the post-COVID clinic, we are seeing like you said, a third, and a third. We are seeing so much of fibrosis that, now I'm beginning to see, cor pulmonale in 50 years old who never smoked or never had lung disease.
So, Kay, in terms of the patients who are in your ICU who are crashing and deteriorating, absolutely. You do the echocardiogram, you find the right ventricle is dilated, it is failing, interventricular septum is shifted over, and no question. And that's how those patients ended up dying. And we were giving those patients trials of nitric oxide empirically, etc. On the other hand, when the patients are discharged and you have a patient population that has some amount of fibrosis, has some amount of ground glass, but are still coming back to you and saying, when I walk, I get short of breath, and you do a 6-minute walk test and you find that they are desaturating, it's in those patients that, and I probably have not a large number, I probably have about 10 such patients where we have done stress echoes and probably 2 or 3 in whom we wanted to absolutely make a diagnosis. So we did right heart catheterizations, didn't find elevation, and therefore chose not to put them on advanced vasodilator therapy.
I think Dharani, your trainee, and my faculty, my star faculty, is on the line, and she would like to. Dharani, you want to make a comment on the Flolan? And
thank you, Dr. G.
Yeah, go ahead.
Yes, thank you. It's a pleasure to be on here on this platform, and I got the training from Dr. Rauf, and I'm under care of you. We have extensively used inhaled Flolan, that's the ipoprostenol, for these patients who suddenly deteriorate or we're not able to oxygenate. We can temporarily increase their oxygenation, and we have seen some improvements in few. It's hard to say how much it is improved, but that's something we've been using extensively in the last 1 year.
Yeah, and I would agree with that, Dharani. First, pleasure to see you. It's always nice. Yes, in those acute instances when your back is to the wall and the patients are not doing well, we have also routinely tried nitric oxide or inhaled Flolan as well. We have tried, but what about the chronic patients in whom there is hypoxemia? You discharge the patients and you follow them up, let's say 6 weeks, a couple of months later. What has been your experience in terms of their pulmonary artery pressures?
We are treating them like almost group 1. I mean, we do extensive of immunological workup to see if there's anything related to connective tissue or other routine way of addressing pulmonary hypertension. But mostly it's attributed to the post-COVID. And we are giving them inhaled vasodilators and see if they respond. Of course, the experience so far is limited, but we have been trying those modalities.
Sure.
I
And
think
you would use those if the pulmonary artery pressures are not elevated on an echo, or are you finding pulmonary pressures elevated on your echoes?
They are elevated on the echoes. Yes, absolutely. That's a screening test. And then we have done some right heart caths in these patients, and who are elevated for sure are getting the treatment.
Great.
I think I would just like to take some questions from the chat box, and then we go back to Dr. Prem Kumar. We may run a few minutes over. Suhail, I know you're 1 hour ahead of us, and I know you like to get up at 4 o'clock. I know that to do your run. They're asking, is there any role of N-acetylcysteine? Is it a good drug to start early in the disease? And second question is, more liberal use of prophylactic anticoagulation, even in high-risk cases in elderly patients where D-dimer is not yet raised.
Right. So what I would say is I have no experience with N-acetylcysteine. I don't think that there is a lot of published data. We had a study that was started approximately 3 months ago in utilizing antifibrotics, where we were looking to try to see if by utilizing OFEV, nintedanib, etc., we could inhibit the profibrotic pathways in patients who continue to show worsening of reticular opacities and worsening of gas exchange after discharge. Unfortunately, we were not able to enroll a requisite number of patients because physicians chose not to have a control arm. They chose to give those patients steroids, so enrollment became very difficult. There is a theoretical advantage to using these inhibitors of profibrotic pathways, and these are that they may inhibit the broad pathways that promote fibrosis in the lungs, and they may inhibit the laying down of fibroblasts, which would worsen the interstitial lung disease. The problem is that these drugs don't address the immune dysregulation with COVID-19, and antifibrotics are really meant generally for chronic fibrotic disorders. These antifibrotics do not reverse the fibrosis that has already set in place. And therefore, the general feeling is that you try reasonable doses of steroids, 0.5 to 1 milligram per kg, oral prednisone, for instance. And if you give the steroids for about 1 to 2 months, and then you find that the patients continue to deteriorate, and the CT scan is showing progression of the reticulation, traction bronchiectasis, and fibrotic-like reactions, then combining the antifibrotics along with steroids may make sense. But we do not use these agents upfront or in the beginning unless there are extenuating circumstances.
I think you've answered another question that was there, how long you use steroids for organizing pneumonia. I think we'll go back to Dr. Prem Kumar in the few minutes that we have left.
Okay, thank you, ma'am, for the opportunity. Actually, I would like to touch upon 2 day-to-day clinical problems, what all our physicians encounter. As you know, we all facing the problem of mucormycosis in India with this COVID, all the more after the use of TOSI and indiscriminate use of large doses and prolonged courses of steroid. So my question is, how can we radiologically on CT differentiate between, if we find rounded lesions, ground glass, or atoll sign, that is a reversed halo sign? How can I differentiate between whether it is a COVID lesion or an angioinvasive lesion of the fungal origin, or COP or BOOP, cryptogenic organizing pneumonia?
Yeah, so great question. I think that in terms of mucormycosis, there have been quite a few case reports, and this is before COVID set in, quite a few case reports of patients developing the reverse halo sign. Not ground glass opacities, but reverse halo is more common with mucormycosis than it is with aspergillosis. Now, in the setting of COVID, if you were to show me a reverse halo sign, then it is, I would say to you that the CT would not itself distinguish between mucormycosis and organizing pneumonia. Organizing pneumonia very, very, very rarely will cavitate, whereas mucormycosis is a fungus that invades into the bloodstream, and it is not uncommonly, when it causes vascular invasion, not uncommonly associated with what is called the crescent sign, where you have an opacity and you have a sliver of air adjoining. If I looked at, and I'm speaking to you from the experience here in New York, if I looked at a reverse halo sign, I would try to see if there are prior images. And if I find that there was ground glass opacity that has evolved into dense consolidation, and over a 2-week period or so, that dense consolidation is beginning to show an area of central clearing, I would say to you that it is more likely that this is organizing pneumonia. Can I be sure? I cannot. And certainly, I don't think we saw one case of mucormycosis here. We had Candida, we had Aspergillus, didn't see mucormycosis. But I would look at other signs. We would send off serologies for fungus, beta-D-glucan, galactomannan for aspergillosis. It may be negative with mucor, but I would look at other things. I don't think that the CT is going to allow you to hang your hat on it. If there's cavitation in that area, then yes, it would be very unlikely to be organizing pneumonia.
Thank you, Dr. Suhail. And in the follow-up of a COVID pneumonia, how long would we wait to say that this particular fibrosis is not going to resolve in future? Because patients will be asking, when do we repeat a CT? Definitely we say not, but they are concerned, and we too are concerned in extensive disease at the onset. How long we have to wait to observe whether the lesions are totally resolved or went in for fibrosis, or this fibrosis is not going to resolve yet? Because already it has been more than 1 year. I think by this time, the radiological follow-up studies would have been out.
Yeah, so I think that I would separate that into two specific issues. One is the person has developed scarring and a fibrotic reaction, may have bronchiolectasis and some traction bronchiectasis, but is clinically stable and is not clinically showing worsening of gas exchange. In those instances, I would probably get a CT at around 2 to 3 months and make sure that it is not evolving into what may become reminiscent of organizing pneumonia, because if it is organizing pneumonia, then you would end up giving the patient steroids for a longer period of time and possibly down the road add macrolides. On the other hand is the patient in whom you are noticing clinical deterioration. And if there is clinical deterioration, then I would tend to be a lot more aggressive. And those are the patients in whom we have tried to get sometimes surgical biopsy done, understanding the complications of surgical biopsy with diffuse lung disease and fibrosis. We have found in some instances eosinophilic pneumonia. We have found in some instances diffuse alveolar damage reminiscent of ARDS. And we have found almost in 15% of the patients in New York some type of organizing pneumonia. Now, the organizing pneumonia may be just a red herring and may be present with other inflammatory conditions in the lung, but irrespective, those are the patients where there's clinical deterioration, where I would tend to be aggressive, where I would tend to give higher doses of steroids, where I would tend to consider the possibility of starting antifibrotics. There have been a few instances where things like mycophenolate have also been tried in those instances where patients could not be weaned off steroids and they were running into problems, or you had kept them on steroids for 3-6 months and you needed a steroid sparing agent.
My final question, Dr. Suhail. See, a lot of cases of happy hypoxemia. Patients are hypoxemic, but they are not breathless. Their work of breathing is not increased because of good compliance. So radiologically, can we conclude that on a CT, if extensive GGO is there, good compliance, extensive consolidations are there, because they are dense, I feel more amount of exudate and tissue. So poor compliance. So can compliance be studied in terms of GGO versus consolidation?
Yeah. So, this was an interesting concept that was proposed by Garinoni, and this had come out in the month of May and June of last year, where they said that there are two phenotypes of COVID patients, those who had lowered compliance and those who had normal compliance. And the feeling was that those patients who have stiff lungs may benefit more from giving them high levels of PEEP, giving them, low tidal volumes and lung protective strategies. There have been several discussions with Garinoni in the mix and Nick Hill and others, and I was able to participate in some of those discussions. And it does not seem that theory holds true. This concept of happy hypoxia is perplexing to me, because in my book, hypoxia is never a happy hypoxia. These individuals, as you're rightly pointing out, do have good compliance, but they are hypoxemic, and as a result of the hypoxia, their chemoreceptors are getting stimulated, and that is the reason why they're taking large tidal volumes in. They don't seem to be very uncomfortable, but this is the patient population where self-induced lung injury is likely happening with every breath. And until and unless we can somehow get the tidal volumes to be low, there have been editorials written where they've said you may be better off intubating the patients and sedating them, and if necessary, paralyzing them, because these are the patients who don't do well with the self-induced lung injury, large tidal volumes, not very symptomatic, but significantly hypoxemic.
Thank you, Dr. Rauf. My cardiology friend frequently calls me up and says, emergency, grade 4 breathlessness. Tell me urgently whether it is pulmonary edema or COVID in this COVID era. So I said a cardiomegaly, a fissural edema, a pleural effusions, basal predominance will be in favor of a cardiogenic pulmonary edema. Apart from this, do you have any thoughts over this?
No, I think that that is absolutely appropriate. And as Kay was mentioning, that utilizing point of care ultrasound in trying to distinguish may also be helpful. If you see B lines, etc., then that's something that the ultrasound could also help in distinguishing whether it is pulmonary edema without having to move the patients down. But the usual signs that you talked about on the chest X-ray or the CT scan, looking at the D-dimers, looking at pro-BNP in those patients, doing a good clinical examination. Our Indian doctors are excellent at physical findings, JVD, hepatojugular reflux, the usual stuff that you do in conjunction with perhaps ultrasound.
Thank you, Dr. Rao. Thank you so much.
Very
Thanks, madam, for giving me that.
Dr. G, I think we kept our guest speaker, having promised him 1 hour, we kept him longer than an hour and a half. We should let him return to his rest.
Yeah, I agree. Thank you so much, Suhail. That was fantastic. I've taken screenshots of the comments, all the compliments that you got, and I'll send them to you. Thank you so much. And we may do this in future, maybe like a wrap-up session in a month or so, just, as they have more time, and definitely we'd like to hear back from you.
Happy to participate. Thank you so much, and good to see you all. And Dharani, take care of yourself, and Kay and everybody else.
Dr. Rauf, Dr. Sudhakar is the principal of our medical school. I think he's on and he will say good night.
Yeah, thank you, Dr. Kairam, and thank you very much, Dr. Kalpalata Gulpalli, for bringing in Dr. Rauf. Dr. Rauf, your presentation has been an extraordinary one, and we cannot expect anything better than this. And I wish that you would come again with more information later, maybe as Dr. Gulpalli was telling us. And wonderful session we had, and thank you very much, all of you who have participated in this. And that's all from my side, and thanking you once again. And Dr. Kairam, over to you.
Thank you very much, Dr. Rauf. On the behalf of Andhra Medical College, we appreciate the time that you've given us and an extensive and very detailed talk. Thank you very much.
My pleasure. Thank you so much. Good night.
To the rest of you, we'll meet again tomorrow night. It will be Dr. Pratit Kulkarni. I've been talking to him for the last few days. He's going to round up all of the ID questions for us. Thank you all. Good night. We'll see you tomorrow night. Thank you, Dr. Rauf.
Thank you so much. God bless.
Dr. G, good night.
Bye.